So hello everyone, welcome to the Zoom meeting. Today the Brown team will take care of the meeting, and Mihir will
Yes.
mentor or lead the meeting. So when you are ready, you can start. But before that, I want to ask everyone if you can just a reminder to make sure your name is written on your account so that we can call your name the right way or the way you want us to call you. Thank you. Go ahead.
Thank you, Dr. Nadir. And good afternoon and good evening, everyone. Welcome to our telegeriatric weekly meeting. And my name is Mihir. I'm the moderator of the Brown team. And I thank Dr. Nadir to give us this opportunity. And today we're going to start with our first presentation about the diabetes mellitus part 2. And I would like Dr. Saria and Dr. Saima to invite and do the presentation. Dr. Saria, are you there?
Yes, hello everyone.
Hello.
I hope everybody doing well. Hello, Dr. Nadir.
Hello.
Thank you for the opportunity for us.
Please go ahead and share your screen.
Yes, just 1 second.
Sure.
Hello, everyone.
Hello. You have an echo.
Yes, I got it. Sorry about that. Do you hear me? And the screen is clear?
Yes.
Okay. Just to remind you that my name is Dr. Saria. I want to represent diabetes mellitus today among pediatric population. So this presentation will be able to describe epidemiology of the diabetes in older adults, how to classify and diagnose diabetes, a strategy to prevent diabetes and managing risk factors, the clinical evaluation of older adults with diabetes using evidence-based guidelines, and how to develop individualized diabetes management plan based on each patient's goals, values, and preference. This presentation is also, it has to be able to describe how to manage hypertension, dyslipidemia, microvascular complication in patients with diabetes, pharmacological management of diabetes, the management of diabetes across continuum of care. So, epidemiology of diabetes in older adults, also we will describe it here, pathophysiology of diabetes in older adults, diagnosis and evaluation of diabetes, prevention of diabetes, managing diabetes and its complications, intervention for diabetes care, which include control of comorbid illness, education and self-management support, and medications. sorry. One of the most common, now we will start to talk about epidemiology, that one of the most common chronic disease, as we all know, affecting older adults, of people 65 or more years old, 27% have diagnosed or undiagnosed diabetes. Age-adjusted prevalence higher among Black and Hispanic American than white American. African Americans suffer from complication of diabetes as disproportionately higher rate than white American. Older adults with diabetes have higher rate of vascular complication and geriatric syndromes. Some of us may ask about what is a geriatric syndrome. The geriatric syndrome has multiple comorbid issues that occur to geriatric population, like dementia, dehydration, depression, delirium, incontinence, vertigo, and falls. All these called geriatric syndromes. A 10-year reduction in life expectancy and mortality rate nearly twice that of people without diabetes. Mobility problems, disability in their activity of daily living. Okay. Type 1 result from absolute deficiency in insulin secretion due to autoimmune destruction of pancreatic B cells. And type 2 diabetes, usually due to tissue resistance to insulin action and relative insulin deficiency. This means that in diabetes type 2, there is no absolute deficiency of insulin. So diagnosis of diabetes made by multiple ways. We can do hemoglobin A1C if we found it. It's like 6.5% or more. This is diagnostic. Or the patient maybe have symptom of polyuria, dyspepsia, unexplained weight loss, plus random plasma glucose 200 milligram per deciliter or more. Or we can use plasma glucose after 8-hour fasting. If we found it 126 milligram per deciliter or more, we can diagnose diabetes. Or we can use plasma glucose 200 milligram per deciliter or more, measured 2 hours after ingestions of 75 gram glucose in 300 ml water, administered after an overnight fasting. Nobody go to make 2-hour postprandial glucose after patient fasting and eating by themselves. You have to give him 75 glucose in 300 ml. And then you can measure the glucose in his blood. Must be confirmed on subsequent day, not just one reading. You have to subsequent day. You have to do a test in subsequent day, preferably by the same method. Don't use 2 methods. Use same method to measure the blood glucose. No adjustment for age. Are you guys following me? My voice is clear?
Yeah, we are.
Yes, yes.
I appreciate that. Thank you.
Yes.
Okay. Oh, sorry. So prevention of diabetes. There is several diabetes prevention trials demonstrate lifestyle modification that focus on diet, exercise, weight loss can delay or prevent progression to diabetes in people with impaired glucose tolerance at high risk of developing type 2 diabetes. Okay, to evaluate the risk factor for atherosclerotic disease and presence of comorbid disease, it has to evaluate the risk factor for patients with diabetes. Take through medication history, assess functional status, screen for common geriatric syndromes, as we mentioned before, the functional impairment, urinary incontinence, falls, pain, cognitive impairment, depression, are more common in older adults with diabetes. Psychosocial assessment involving family members, barrier to adherence. Okay. Goals should be individualized, clinical target for each older adults with diabetes involving the caregiver when appropriate. Management goals should include control the hyperglycemia and its symptoms, evaluate the treat associated risk for atherosclerotic and microvascular disease, evaluate and treat diabetes complications, avoid hypoglycemia. Also, must consider life expectancy and time needs for clinical benefit from a specific intervention in treating older adults with diabetes. Some clinical trials have demonstrated that greater than 8 years are needed before the benefit of glycemic control are reflected in reduced microvascular complications such as diabetic retinopathy or kidney disease. So tight control of glycemic blood or tight control of hemoglobin A1C does not affect macrovascular complication of diabetes, which is reflected in stroke and other things. So if we control the diabetes tightly, we have to wait for 8 years to control microvascular complication. Only 2 to 3 years are required to see benefit from better control of blood pressure and lipids. So general principles of management. Evidence support that effectiveness of several components of diabetes care. It's control of diabetes and blood pressure. We have to advise the patient to stop smoking and appropriate eye and foot care. Diabetes education and self-management support for medication adherence. This is more important things. Appropriate nutrition, weight loss, if indicated, not for all patients, increase physical activity. Home monitoring of blood glucose has not been found to be cost effective. So older adults with diabetes should undergo age-appropriate prevention interventions such as influenza, pneumococcal vaccination. Careful annual food examination is recommended due to lower extremity infection and mutation being more common among older adults with diabetes. Screening for kidney disease by testing for presence of microalbuminemia should be performed at diagnosis as baseline and annually. If the patient is taking an AC inhibitors or angiotensin receptor blockers, there is no need for continuity screening. Once you found that there is microalbuminemia and prescribed AC inhibitor, you not need for continuous screening for microalbuminemia. So that drug will take care of all things. So education on self-management support. We have to educate the patient and caregiver about hypo and hyperglycemia, precipitating factors. They have to know prevention, symptoms, monitoring, treatment, when to notify the physician. Blood glucose self-monitoring when appropriate, diet and physical activity, medications, purpose of the drug, how to take it. It's a very important things, common side effects. So they have to be aware of the side effects of the drug, important adverse reaction, and the food care, as we mentioned before. So prevention and control. Sorry about that. So prevention and management of cardiovascular risk factors counsel the patient regarding first, maintaining appropriate weight, increasing physical activity, discontinuing smoking, limiting fat and carbohydrate intake. consider drug therapy to treat hypertension, prevent the MI, myocardial infarction, with use of aspirin, treat the dyslipidemia. So best target blood pressure for older people with diabetes is unclear. It's important to use patient-centered approach. For healthier patients with a few comorbidities and functional limitation, target blood pressure of 120 to 140 systolic and 70 to 80 diastolic may be ideal. In some older adults, the same harms may outweigh the benefits of the treatment. Orthostatic hypotension leading to the fall and potential hip fracture resulting in functional limitation. Manage of hypertension. Sorry guys, just 1 second. Sorry about that, guys. So management, we will continue in hypertension management in patients with diabetes, lowering blood pressure gradually to avoid complication. Most antihypertensive drug class have comparable effectiveness. ACE inhibitors and angiotensin 2 receptor blockers have cardiovascular and renal benefit for people with diabetes. When we came to management of dyslipidemia, should be corrected if reasonable, considering the patient's overall health. So measure lipid panel and ALT within 12 weeks of initiation, or dose increase of statin or niacin to assess adherence and response. Routine monitoring of liver function test is unnecessary if patients on statins. More potent statin or higher dose appear to increase the risk of adverse effects. So we have to use minimal effective dose for those patients. So guidelines from AHA and ACC and NHLBI state that there is a little evidence that treating to a specific LDL target is beneficial. So if patients have, that is specific to older adults, they recommend it. For adults with diabetes age from 40 to 75 and LDL between 70 and 189 milligram per deciliter, high dose statin are recommended for those with 10-year atherosclerotic cardiovascular disease risk of 7.5% or more, and moderate dose statin for those with 10-year risk of cardiovascular less than 7.5%. Continuation of statin beyond age of 75 is warranted. Must evaluate risk and benefit profile first before continuation in statin for patient age 75. Unclear whether starting statin for primary prevention is beneficial for those more than 75 years old. Preventive to use patient-centered approach and shared decision-making process before starting any medication, especially for pediatric population. There is no evidence that intensive hyperglycemic management prevent cardiovascular outcome. As we mentioned before, it's considered as macrovascular disease, cardiovascular disease, and stroke. tight control of blood glucose, it doesn't show that there is prevention of cardiovascular outcome. Most guideline and expert recommend individualized hemoglobin A1C targets. Healthier older adults with excellent self-management capability striving for hemoglobin A1C targets near 7%, and more frail patients aiming for hemoglobin A1C level closer to 8.5 to 9%. Older adults are high risk for hypoglycemia, so close medication with less risk when possible. So now we'll continue with Dr. Saima Shawl. Are you here, Dr. Saima?
Yes, I'm here.
Yeah, go ahead. Thank you, everybody.
You need to get your office so I can finish.
Your voice is not clear, Dr. Saima.
So yeah, I'll just be sharing my screen. Give me a second. Can you stop sharing your screen?
Sure.
Dr. Saria, yeah, so that I can share my screen.
Dr. Saria, can you please stop sharing your screen?
Sorry?
Can you please stop sharing your screen so Dr. Saima can share her screen?
Yeah.
Thank you.
All right. Just so can you see my screen?
Yes.
Okay. All right. Thank you, Dr. Saria, for your lovely presentation, and hello everyone. My name is Saima Shawl, and I'm one of your fellows here. I hope everyone is doing great today. So let's continue our presentation. So now we will be talking about the non-insulin agents, the oral anti-diabetic therapy. So the first line therapy is bigonides, which are very well known, the metformin. It works by decreasing the hepatic glucose production, and it's very popular because it helps in weight loss, has a low risk of hypoglycemia. However, there are some side effects like GI effects, lactic acidosis, and we have to be very careful if somebody has an impaired renal function profile. The second generations are sulfonylurea, which work by increasing the insulin secretion. However, they can lead to hypoglycemia and weight gain. They have some side effects like GI effects or skin reactions. They can lead to abnormal LFTs. So again, we have to be careful in renal and hepatic impairments. Another class is alpha glucosidase inhibitors. They delay the glucose absorption, and they can, however, lead to hypoglycemia and weight gain. And their common side effects are like GI effects like diarrhea. We have another class, DPP4 enzyme inhibitors like the gliptins. They protect and enhance the endogenous incretin hormones. They have a low risk of hypoglycemia, and they are weight neutral. Moving on, we have megalotinides, which increase the insulin secretion, and they can also cause hypoglycemia and weight gain. Then we have thiazolidinones like pioglitazones or rosiglitazones. These increase the insulin sensitivity. However, they're not good for patients with heart failure. They can lead to edema. They have side effects like fractures. We cannot give them in patients who have class 3 or 4 heart failure, or we do have to avoid them in the patients with the bladder cancer. They do have low risk of hypoglycemia. However, they do cause weight gain. Coming to SGLT2 inhibitors, the flozins, they cause the renal excretion of glucose. They have a low risk of hypoglycemia. they do help with the weight loss. However, they can cause side effects like genitourinary infections, dehydration, hypotension, fracture, etc. Then we have others like bromocriptine, cholecalciferol. The metabolism or the mechanism is unknown. However, they are the bile acid sequestrants, and they can have some GI side effects. Moving on, now we're coming to the insulin preparations. Now we have some rapid-acting insulin preparations like insulin glucine, Lispro, S-Part. So the peak time for glucine is 0.5 to 1.5 hours. Same goes for Lispro. S-Part is 1 to 3 hours. Then we have inhaled ones also, and the peak time is like 1 hour. Coming to the regular ones, we have Humulane, Novolane. Their peak timings are like 2 to 3 hours. Then we come to the intermediate or the long-acting ones. We have NPH, we have insulin, and we have NPH, which has a peak of 4 to 12 hours. We have insulin Detrimer, insulin Glargine, and Degludec. These have a peak of 6 to 8 hours. Glargine is, however, peakless insulin, and Degludec has a peak of 12 hours. Then we have some combinations, like we can combine the isophane insulin with a regular insulin injectable, or we can combine the insulin risproprotamine suspension and insulin Lispro, and there's a combination of Degludec and insulin S-Part. Now, what could be the most important issue concerning the patients is taking those, especially those who are on insulin. So hypoglycemia, yes, this is a very, there's a very high risk of this serious complication in the frail older adults. Now, which agents are more likely to cause hypoglycemia? So the longer acting sulfonylureas like glyburide, they are more common to cause hypoglycemia than the shorter acting ones like glipizide. Also, the patients or the older adult population who have a history of hypoglycemia or multiple comorbidities, or who have a poor functional status, they should use the short-acting ones, or they should use the oral antidiabetics versus the insulin. Now, there is a treatment plan, a stepwise approach, so taking into consideration HbA1c and the symptoms. So if somebody is having an HbA1c 6.5, between 6.5 to 7.5, we go for lifestyle management initially. Now, if your hemoglobin A1c is 7.5 to 9, then we add on to a monotherapy. Initially, we usually take metformin into consideration. And if your hemoglobin A1c is ranging between 9 to 10, then we use a dual therapy. We can keep the metformin and add a second agent. The second agent could be anything from the oral agents, DPP4 inhibitors, SGLT2 inhibitors, GLP-1 receptors, or anyone. Then if your HbA1c is more than 10, we usually add insulin, and we can, keep metformin accordingly. The second step is to reassess the hemoglobin A1c at 3 months, and then we adjust the treatment plan accordingly. Now, if the individualized hemoglobin A1c targets have not been reached, then we do consider more aggressive treatment strategy, or accordingly, we do consider a less aggressive treatment target according to the hemoglobin A1c results. Step 3 would be to continue to reassess the hemoglobin A1c every 3 to 6 months. If not at target, then and every 6 to 12 months if at target. And then we adjust the treatment plan as necessary. So management of diabetes across the continuum of care. Now, if the patients are in hospital, so there's a nice sugar trial. So we see the risk of the severe hypoglycemia and mortality was increased with a tight blood glucose control. So we hold the non-insulin therapies, and Insulin, if you have a persistent blood glucose more than equal to 180 mg per deciliter, and it's adjusted to a target 140 to 80 for critically ill and non-critically ill patients. Now, the basal bolus insulin with or without correction regimens lead to a better glycemic control and reduced hospital complications than sliding scale alone. We can have like hypoglycemia protocols are there for the blood glucose less than 70 mg per deciliter, and we can communicate with the outpatient providers on the discharge. So in case of a skilled nursery facility, 1/3 have been documented with side effects like hypoglycemia. This could be because of the less regular food intake taken by the older adults. So we can establish the protocols to alert the medical providers so that the management of the diabetes can be assessed and adjusted as necessary, be it for hypo or hyperglycemia. In case of the palliative or hospice care, we usually follow a less stringent approach to the glycemic control. Stable patients, we prevent hypoglycemia and symptomatic hyperglycemia, because that can lead to the dehydration in this patient population. We can titrate down the insulin dosage as oral intake declines in the organ failure in people who are in hospice care. So in case of dying patients, we stop all the agents in type 2, and we also decrease amount in type 1 diabetes. How to choose wisely. Now, we do have to avoid using medications to achieve a hemoglobin A1C less than 7.5% in most adults who are more than equal to 65 years old. Moderate control is generally better. Now, we don't have evidence that using medications to achieve high glycemic control in most older adults with type 2 diabetes is beneficial. Now, we see that among the non-older adults, except for those who have long-term reductions in the myocardial infarction and mortality with metformin, using medications to achieve a glycated hemoglobin level less than 7% is associated with harms, including higher mortality rates. Tight glycemic control has been constantly shown to produce higher levels or higher rates of hypoglycemia in older adults. Given the long time frame to achieve theorized microvascular benefits of tight control, the glycemic targets should reflect the patient goal, health status, or life expectancy. So the reasonable glycemic targets would be between 7 to 7.5% in healthy older adults who have a long life expectancy, and it could be between 7.5 to 8 in those with moderate comorbidity and life expectancy less than 10 years, and between 8 to 9% in those with multiple comorbidities and shorter life expectancy. Now, in a nutshell, diabetes is one of the most important diseases we need to identify and address. Because of its greater heterogeneity in the older population, treatment goals for diabetes must be individualized. Although the target is debated, attempts to lower a blood pressure as tolerated are important for older hypertensive patients with diabetes. Diabetes self-management is also an important part of the diabetic care, and annual self-management training is covered by Medicare Part B. So now let's go through some questions and cases. So here's the first case for us. So a 65-year-old woman comes to the office for her welcome to Medicare preventative visit. She uses a 4-wheeled walker to assist with ambulation. Her history is of that of diabetes, diagnosed 3 years ago. She has hypertension, osteoarthritis of the knee and hip. She is taking medications like acetaminophen, tramadol, metformin, lisinopril. So on examination, we see that her BMI is 30. There is nothing remarkable cardiovascular or pulmonary findings, bilateral knee crepitus with extension with no focal pain is seen. With the walker, her gait is stable but slightly wide-based with a decreased knee flexion. Her HbA1c is 8.5%. So, which of the following is the most appropriate recommendation? A, weight loss to achieve normal BMI. B, diabetes. Diabetes self-management education program. C is prescription for glipizide. D is exercise prescription for walking 150 minutes per week at moderate intensity. So who wants to go for it? You have 10 seconds. You can write your answers in the chat box if you want to try it. Anybody? Okay. Okay, let's see the answer. So which of the following is the most appropriate recommendation? So the answer is a diabetes self-management education program. Okay, let's move on to our second case. So here we have an 80-year-old man. He comes to the office with his son, who is concerned about his father's memory. Now, the patient's wife died 9 months ago. He says he feels lonely at times, but is not depressed. The son notes that his father has gotten lost a few times when driving to church, and there are unpaid bills lying around the house. History shows type 2 diabetes, diagnosed 20 years ago, mild knee osteoarthritis, well-controlled hypertension, and his medication list includes aspirin, losartan, hydrochlorothiazide, metformin, insulin glargine, insulin lispro. According to his chart, the prescriptions expired 2 months ago and he missed his last 2 appointments. The lab findings 1 year ago showed a normal electrolyte level, normal renal function, and hemoglobin A1c 7%. Today, his hemoglobin A1c is 9.5%. He has a normal thyroxine level and thyrotropin level is 8. So which of the following is true about this patient's memory changes? A, his executive dysfunction is unlikely to be related to his diabetes. Hyperglycemia is likely impairing his cognition. Correcting his hypothyroidism will likely improve his cognition, or tight glycemic control will likely improve his cognition. So what do you guys say? Okay, you can see C. Keep writing on the answers, guys. C, okay, B, somebody said B, okay. A few more seconds. C, okay. Majority is going with C. Okay, C. All right, let's check the answer. So the correct answer is B. It's hyperglycemia is likely impairing his cognition. Okay, that was an interesting one. So let's see if we have more cases. Yeah. So here we have a 72-year-old woman comes to the office to follow up on recent lab findings, which included a hemoglobin A1c of 9%. Now she lives alone. Hired home health aide helps her with the grocery shopping, laundry, and house cleaning every day for about 3 hours. She uses a walker for mobility. Because of a fear of needles, she refuses to monitor her glucose at home. Her history shows type 2 diabetes, which was diagnosed 5 years ago, hypertension, hyperlipidemia, advanced glaucoma, severe knee osteoarthritis, and osteoporosis. Now, her medications include metformin, lisinopril, atorvastatin, alendronate, aspirin. Physical examination shows BMI of 28, blood pressure is 140/70. All other findings are unremarkable. Which of the following is the most appropriate management in this case? A, continue current regimen, add hydrochlorothiazide, add glipizide, or add sitagliptin. So what do you guys say? Anybody? Anybody, guys? Which one is the most appropriate management? Do we add hydrochlorothiazide, glipizide, sitagliptin, or we continue the current regimen? Okay, D. Anybody wants to try? You can write in the chat box. Okay, D. Oh, sure, I can show you the scenario again. 1 second. So the scenario is here, 72-year-old woman, hemoglobin A1C of 9. She's living alone. She's using walker for mobility. She doesn't check her glucose. She has diabetes, hypertension, hyperlipidemia, glaucoma. Medications are metformin, lisinopril, atorvastatin, alendronate. BMI is 28, blood pressure is 140/70. So which one is the most appropriate? B, D, okay, D, D, okay. All right, let's check the answer. Thank you for trying, everyone. Let's see the answer. Okay, so most of you said D. So let's see. So the answer is D, right? So we will add sitagliptin. Good for those who chose D, and good for those who tried it. Okay, let's see what's next. Oh, that's it. So this was the last case. So thank you, everyone. I hope you had a good time listening and did not get bored. So yeah, thank you so much. You all have a good day. I'll see you again at the next slide. Thank you.
Thank you. Thank you, Dr. Saria and Dr. Saima, for your wonderful presentation. Dr. Nadir, any comments on that?
I think thank you so much, both of you, for great presentation. And it's a major topic, and you went through. This is just the shorter version. But if you want to focus on the last couple of slides, the main issue is you want to control the diabetes in older patients, but not like younger patients. And there are some goals. You don't look at the number per se, you look at the functionality of the patient. So depending on different factors, the target of the A1C or the diabetes will be set. So it's important to look at the whole picture instead of looking only at lab or numbers like A1C or what their blood sugars every day look like. The goal is to prevent complications and not to overdo it, like you end up with hypoglycemia, and patients may die because of that. So it's fine balance. But thank you so much, both of you, Saria and Saima. That's excellent, great presentation. Munir has a question.
Nadir, I appreciate that. And moving forward, this our second presentation today is
Can we just listen to one question,
sure,
maybe
sure.
from Munir?
Hi, Munir. My name is Munir. Thank you, Dr. Nadir. Thank you to the moderator and thank you to the speaker. Both of you doing a great job. I don't want to take much of the time. My question to Saria, the slide before the management of hypertension. I hear aspirin. Can you go back and just slide? I hope I didn't take much of your time.
Just 1 second.
Is the question clear, Saria?
Yes, the question is clear. I want to go to
Thank you.
this one. Sorry about that. Sorry for late. I want to just share the screen. So you ask about
Use of aspirin in management of diabetes per se, I mean.
While Saria is uploading or sharing the screen, I just want to share with you. I had one case, and it's an interesting case because the patient has multiple complications from diabetes. She is in her late 90s, I presume, but the family is concerned when I took care of the patient that her blood sugars are very high. And the reason they kept track of blood sugar like we check it 4 times, let's say a day, and they shared that with me. So I told them we can look at the causes for the blood sugars and we can control it better. We can do that slowly so that we don't get complication of tight control like hypoglycemia. So one of the daughters was very aggressive. She did not like my answer. And a few days later, the patient was sent to the hospital and she was found to have some infection. She has a renal stone and recurrent UTI and infections. So they put her on some antibiotics at the hospital, but it seems the daughter raised the same question, why the blood sugars are high, 300, 400, 500. So the doctor at the hospital, I assume just from reading the numbers or the records, tried to tightly control the blood sugar. And guess what? The patient during her hospital stay, she had hypoglycemia. Thanks God she didn't have problems, but the way to control the blood sugar is taper either up or down slowly in older adults. So sometimes we need to educate the patients, but more important, their family members. Thank you. Go ahead, Saria.
So what is your question again, please?
Yeah, thank you so much. So the slide before that, you mentioned prevention of MI and use of aspirin. Just the slide before this one.
Yes, just answer.
Yeah, this one.
Mm-hmm. Yeah.
According to my knowledge, in the previous, there was use of aspirin for prevention of MI. But nowadays, you cannot use aspirin to prevent MI because of the risk of there is high risk of bleeding. According to the new studies, you cannot use aspirin unless you have an evidence of ischemic heart disease or ischemic stroke or something like that. And the risk of bleeding is high, especially in elderly and especially in female. So if you compare between the benefit and the risk of use of aspirin as a prevention, nowadays aspirin is not used as a preventive measure. And this is according to the American Association of Cardiology.
So nowadays I'm working in a cardiology clinic, and we found our boss using aspirin, baby dose aspirin for all patients with coronary artery disease.
Oh, yeah, correct. If the patient has coronary artery disease, confirm, absolutely yes. But if the patient has diabetes without evidence of coronary artery disease, you cannot use aspirin. This is my points. If you have a confirmed coronary artery, yes, for sure, for life, you have to use aspirin. And if you have ischemic stroke, yeah, if you have ischemic stroke, you can use aspirin. But for diabetes per se, without evidence of coronary artery disease or ischemic stroke, there is no use of aspirin nowadays, according to the American Association of Cardiology.
Okay, thank you. Thank you very much, Dr. Munir.
Welcome.
Thank you.
Hello, everyone. Hi, Dr. Nadir.
I
just want to add to what Dr. Munir says, that I know that the United States Preventive Service Task Force recommends that we use aspirin in with certain factors, just as Dr. Munir said. The first one is that the patient should be from 50 to 59 years old. I'm talking about the preventive use of aspirin, not in patients who are already have established cardiovascular disease. Like for prevention, a patient should be from 50 to 59. They have a life expectancy of more than 10 years, and they can adhere to daily aspirin dose. Also, they should not have any risk factors for bleeding. So this is according to the United States Preventive Service Task Force. Thank you.
Thank you. This is actually new to me, this point, what you mentioned. Thank you so much.
You're welcome, Dr. Munir. You can check their website for this guideline. I think it's new. I'm not sure at which year, but this is what I know.
Okay, thank you so much.
You're welcome.
Thank you, everyone. Looks like Dr. Sehab has a question. Go ahead, please.
Yes, good evening, everyone. It's not a question, just I want to comment more about what the doctors previously said about the aspirin use. Is it today they're using the aspirin to prevent ischemic heart disease or just blood thinner? Because, as we know, the risk of bleeding with hypertension people, and as I know that they use the statin to prevent the ischemic heart disease. They do the risk of heart disease, and they can use anti-lipid medication instead of aspirin, because aspirin we can use it for transischemic attack or something that we have proved that this patient already developed vascular issue. So my point is it logical to jump to aspirin instead of using the anti-lipid first?
So to answer some of this question, I think in geriatric in general, there are some bodies like the American Association for Cardiac or Cardiology, the European also, or other guidelines. So sometimes they agree in the general approach, and sometimes they may differ, specifically like the European versus the American in certain aspects cut off. And the problem, it seems, when they look at the literature, some of the research done, they don't include typical patients. So we have patients with heart problems And diabetes, sometimes we have diabetes with, let's say, kidney disease. And some of these might be excluded from some of the studies. So when they come to the conclusion in this, like in the US, they may have different recommendations compared to studies or other places like Europe. So in general, we want to look at the latest, and if there is consensus between these identities or these recommendations, we carry on. Sometimes it may be difficult to come to the conclusion, so you can follow each one according to your location or your preference. So it's a big topic as far as following the recommendations. As I mentioned, in my case, if the patient that I saw was presented to the American Geriatric Society, they will say you did the right thing as far as my controlling the blood sugar gradually and slowly. If you go to the general guidelines, you may find different approach, and you may get in trouble because of that if the family started a case or lawsuit against you. So it's a unclear area. So we will discuss this in the future.
Hi, Dr. Nadir.
Yeah, go ahead.
Yeah, I checked it now. They say like if the patient more than 60-year-old, USPSTF recommend against initiating low dose aspirin for them. The study is published like 2022. I can share it with you now if you want. Can you hear me?
Yes, go ahead.
I checked the website of the USPS, and they say for adults age 40 to 59 years with 10% or greater cardiovascular risk, the decision to initiate low dose aspirin use of primary prevention in adults age from 40 to 59 who have 10% or greater risk should be in any individual one. Evidence indicate that the net benefit of aspirin use in this group is small. Persons who are not at increased risk of bleeding and are willing to take low dose aspirin daily are more likely to benefit. For adults 60 years old or older, they recommend against initiating low dose aspirin. This is all. This is the new guideline. I found it. I'm sorry for interruption. Nadia, I finished.
Okay, thank you everyone for the input, and we'll move forward if nobody has any more question. Dr. Saima, can you please stop sharing your screen? Okay, so we'll move to the next presentation that will be on how to write a systematic review.
I have stopped my screen sharing, right?
Yes, you got it. Yeah, I got it. Thank you.
You're welcome.
Can you all see my screen?
Yes, we can.
Sure. So today I'm gonna discuss about how to write a systematic review, and let's see Many of you probably know the systematic review means that review is conducted according to clearly stated scientific research methods and is designed to minimize biases and errors inherent to traditional and narrative reviews. Both systematic review and meta-analysis have a high level of evidence that are represented by the evidence-based pyramid. Therefore, a well-conducted systematic review or meta-analysis is considered a feasible solution in keeping health clinicians ahead regarding contemporary evidence-based medicine. So as most of you are familiar with this kind of a hierarchy of scientific evidence, where if you see on the bottom is case reports, opinion papers, and letters are weakest. And they are considered to be weakest. And if you see on the top of the pyramid, there is a meta-analysis and systematic review, which is usually followed by RCTs, cohort studies, case control studies, cross-sectional studies, and trials and in vitro studies. Next is, let's go on topic of writing systematic reviews. Conducting a systematic review may be difficult, especially for young researcher or somebody who's new to research. Therefore, understanding of its essential step is very crucial. Therefore, the flow diagram of a detailed, which is coming in the next slide, detailed and step-by-step.
I'm sorry to interrupt, Doctor, but you're still on the first slide. We can't see the slides as you move from one to the next.
Can you unshare and reshare the presentation screen? Thank you.
Sorry about that. Can you see now?
Yes.
Okay. Okay, can you see this one too? Hierarchy of scientific evidence?
Yes.
Okay. Sorry about that. So, are you guys all clear about the hierarchy? Then, okay, I'll move to the next one. Please let me know if you don't see the screen. So writing systematic review, as I mentioned, conducting a systematic review may be difficult for young researchers. Therefore, the understanding of its essential steps is crucial. Flow diagram of detailed and the step-by-step, the stages for systematic review studies aim to provide a step-by-step approach, mainly for beginners and junior researchers. SRMA steps include the development of research question, forming criteria, search strategy, searching databases, protocol registration, title, abstract, full text screening, manual searching, extracting data and quality assessment, data checking, statistical analysis, double data checking, and manuscript writing. Here's the flow chart. Can everybody see this?
Yes.
Yes, I just wanted to make sure, sorry. So just a little brief review about this is when we start researching any topic or anything, we want to research the question. We want to first come up with the question, which is, I'm sure most of you're about to work or start your research project. So I think this is going to be very helpful. And we'll go detailed in each and every part of this flowchart. So let's go from further. Research question and objectives. The research questions should be feasible, interesting, novel, ethical, and relevant. Therefore, a clear, logical, and well-defined research question should be formulated. Two common tools are used. One is PICO or SPIDER. PICO means population intervention, comparison, and outcome. It is used mostly in quantitative evidence synthesis. Authors demonstrated that PICO holds more sensitivity than the more specific SPIDER approach. Spider means sample, phenomenon of interest, design, evaluation, and research type. That was proposed as a method for qualitative and mixed method research or searches. PICO is usually used for systematic review of clinical trial study, for the observational study with or without intervention or comparator. In many tropical and epidemiological questions, it is usually enough to use patient and outcome only to formulate a research question. However, it is necessary to indicate clearly the population, then intervention or exposure. Next, it is also necessary to compare the indicated intervention with other interventions like placebo. Lastly, relevant outcomes need to be clarified. Preliminary research and idea validation. A preliminary search to identify relevant articles ensure the validity of the proposed idea, avoid duplication of previously addressed questions, and assure to have enough articles for conducting its analysis. Moreover, themes should be focused on relevant and important healthcare issues, consider global needs and values, reflect the current science, and be consistent with the adopted reviews methods. Gaining familiarity with a deep understanding of the study field through relevant videos and discussion is of paramount importance for better retrieval of result. The study more likely to be cancelled if a similar study has been published before. Hence, this step is important and shouldn't be ignored. Inclusion and exclusion criteria. Eligibility criteria are based on the PICO approach, study design, and date. Exclusion criteria mostly are unrelated, duplicated, unavailable full text, or abstract-only papers. This exclusion should be stated in advance to refrain the researcher from bias. The inclusion criteria would be articles with the target patient, investigated interventions, or the comparison between two studied interventions. Briefly, it would be articles which contain information answering the research question. Now, search strategy informs a standard search strategy is used in PubMed, then later it is modified according to each specific database to get the best relevant results, assuming if somebody is using PubMed at first and then going to the different database afterwards. The basic search strategy is built based on the research question formulation. For example, PICOs or PICOs. Search strategies are constructed to include free text terms, for example, in the title and abstract, and any appropriate subject indexing. Expected to retrieve eligible studies with the help of an expert in the review topic field or an information specialist. The improvement of the search term is made by doing a trial search and looking for another relevant term within each concept of retrieved papers. Such databases import all results to a library and exporting to an Excel sheet. So, according to assessing the methodological quality of systematic reviews, AMSTER guidelines, at least 2 databases have to be searched in the systematic review. But by increasing the number of search databases, much yield and more accurate and comprehensive results are likely to be obtained. The ordering of the databases depends mostly on the review of questions. Being in a study of clinical trials, one can rely mostly on Cochrane, MRCTs, or International Clinical Trials Registry platform. Several databases such as PubMed, Scopus, Web of Science, Embase, GHL, VHL, Cochrane, Google Scholar, clinicaltrials.gov, MRCTs, Popline, and Seigel are available to cover almost all published articles in tropical medicine and other health-related fields. Among those databases, Popline focuses on reproductive health. Researchers should consider to choose relevant database according to the research topic. Some databases do not support the use of Boolean or quotation. Otherwise, there are some databases that have special searching way. Therefore, the initial search terms for each database need to be modified to get appreciated results. Protocol writing and registration. Protocol registration at an early stage guarantees transparency in the research process and protects from duplication problems. Besides, it is considered a documented proof of team plan of action, research question, eligibility criteria, intervention or exposure, quality assessment, and pre-analysis plan. It is recommended that researchers send it to the principal investigator, PI, to revise it, then upload it to the registry sites. There are many registry sites available for systematic reviews like those proposed by Cochrane and Campbell collaborations. However, it is recommended to register the protocol into Prospero as it is easier. Title and abstract screening. Decision to select retrieved articles from further assessment are based on eligibility criteria to minimize the chance of including non-relevant articles. According to the Cochrane guidance, 2 reviewers are a must to do this step, but as for beginners and junior researchers, this might be tiresome. Thus, at least 3 reviewers should work independently to reduce the chance of error, particularly in teams with a large number of authors to add more scrutiny and ensure proper conduct. Mostly the quality with 3 reviewers would be better than 2, as 2 only would have different opinions from each other, so they cannot decide, while the third opinion is crucial. Full text downloading and screening. Many search engines provide links for free to access full text articles. In case not found, some research websites as a ResearchGate offer an option of direct full text requests from authors. Additionally, exploring archives of wanted journals or contacting principal investigator to purchase it if available. Similarly, 2 to 3 reviewers work independently to decide about included full text according to eligibility criteria with reporting exclusion reasons of articles. In case any disagreement has occurred, the final decision has to be made by discussion. Manual search. One has to exhaust all possibility to reduce bias by performing an explicit hand searching for retrieval of reports that may have been dropped from first search. There are many methods to apply to make manual searching. Searching references from included studies or reviews, contacting authors and experts, and looking at related articles or cited articles in PubMed and Google Scholar. There are 3 consecutive methods to increase and refine the yield of manual searching. Firstly, searching reference lists of included articles. Secondly, performing what is known as citation tracking, in which the reviewers track all the articles that cite each of one of the included articles. And this might involve electronic searching of databases. And thirdly, following all related to or similar articles. Each of the before mentioned methods can be performed by 2 to 3 independent reviewers, and all the possible relevant articles must undergo further scrutiny against the inclusion criteria after following the same records yielded from electronic databases. That means, for example, title or abstract and full text screening. Data extraction and quality assessment. These steps entitle data collection from included full text in a structured extraction Excel sheets, which is previously pilot tested for extraction using some random studies. It is recommended to extract both adjusted and non-adjusted data because it gives the most allowed confounding factors to be used in the analysis by pulling them later. Process of extracting should be executed by 2 to 3 independent reviewers. Mostly the sheet is classified into the study and patient characteristics, outcomes, and quality assessment tool. Data presented in graphs should be extracted by software tools such as Web Pilot Digitizer. A variety of tools are available for the QA depending on the design. ROB2 Cochrane tool for randomized controlled trials, NIH tool for observational and cross-sectional studies, Robbins 1 tool for non-randomized trials, ODAS 2 tool for diagnostic studies, QUIPS tool for prognostic studies, CARE tool for case reports, and ToxR tool for in vivo and in vitro studies. It is also recommended that 2 to 3 reviewers independently assess the quality of the studies and add to the data extraction from before the inclusion into the analysis to reduce the risk of bias. Data checking. Due to the expected humor error and bias, it is necessary to have a data checking step in which every included article is compared with its counterpart in an extraction sheet by evidence photos to detect mistakes in data. When resources are limited, each reviewer is assigned a different article than the one he or she extracted in the previous stage. Statistical analysis. Investigators are used different methods for combining and summarizing findings of included studies. Before analysis, there is an important step called cleaning of data in the extraction sheet, where the analyst organize extraction sheet data in a form that can be read by analytical software. The analysis consists of 2 types, namely qualitative and quantitative analysis. Qualitative analysis mostly describes data in SR studies. Publication bias should be assessed to investigate the presence of missing studies which can affect the summary. Double data checking. For more assurance on the quality of results, the analyzed data should be rechecked from full text data by evidence photos to allow an obvious check for the PI of the study. Manuscript writing, revision, and submission to a journal. Writing based on 4 scientific sections: introduction, methods, results, and discussion, mostly with a conclusion. Performing a characteristic table for study and patient characteristics is a mandatory step. After finishing the manuscript writing, characteristics table, and Prisma flow diagram, the team should send it to the PI to revise it well and reply to his or her comments, and finally choose a suitable journal for the manuscript which fits with considerable impact factor and fitting field. We just mentioned about Prisma. One must follow the guidelines of Prisma to complete the systematic review. Prisma 2020 statement, an updated guideline for reporting systematic review. The Prisma 2020 statement replaces the old 2009 statement and includes new reporting guidance, and that reflects advance in methods to identify, select, appraise, and synthesize studies. Prisma 2020 explanation and elaboration, and updated guidance and exemplars for reporting systematic review. This document is intended to enhance the use, understanding, and dissemination of the Prisma 2020 statement through examples and explanation. The meaning and rationale for each checklist items are presented. I will try to update or send a link in the chat box for both of this document. Prisma checklist. The preferred reporting items for systematic review and meta-analysis, which is PRISMA, is a 27-item checklist used to improve transparency in systematic reviews. These items cover all aspects of the manuscript, including title, abstract, introduction, methods, results, discussion, and funding. The PRISMA checklist can be downloaded in PDF or Word files. PRISMA 2020 checklist, as I said, it can be downloaded. Okay, I will I'll try to send a link in chat box. So finally, just to summarize what we have talked so far, in general, what to include in the systematic review. So for the writing process, which is similar to the process of writing of any other kind of review, systematic review should be provide an answer to the research question. It is not a broad overview of current trends and gaps in research. The review should show the reader how the answer was found, provide the results you have identified. Systematic review must have a detailed methodology that describes the search process and the selection process. This is why careful documentation of methodology is important. A reader of the review should be able to critically interpret the findings to understand why sources were chosen, how they were assessed, and how conclusions were reached. The structure of the systematic review differs from the narrative review or the traditional literature review that allows you to organize it to best support your argument. A systematic review should reflect the stages outlined in the protocol. With a systematic review, reporting guidelines should be followed that help you identify what should be included in each section of the review. One such standard approach is PRISMA. Although much time is invested in developing a search strategy and screening results, a systematic review is valued by the critical reflection and interpretation of the findings. Focus on analyzing, not summarizing. Use a critical analysis tool to assess the studies. Thank you. I think that is it for now. Thank you, everyone. Anybody has any question?
Thank you so much, Mihir.
Thank you, Dr. Najib.
So this is an important overview for how to do the systematic review the right way. Any comments, any questions? I think we can go to the next topic.
Sure. Sure. Thank you, Dr. Nadir. So the next presentation we have on how to do focus group research, and the presenter will be Dr. Saima Shawl. Can you please go ahead? Thank you.
Give me a second, please. Okay. So, hello everyone again. This is Dr. Saima Shawl. I hope you all are enjoying the presentations today and learning from it. So now our next presentation would be about focus research, focus group research. So let's dive into it. So what is a focus group research? So basically, focus group research is a qualitative research method that involves gathering a small group of individuals together to discuss a particular topic or issue, and then this is led by a moderator who will ask the questions to stimulate the discussion and elicit opinions of the participants. So coming to the slide now, As I said, these focus groups are often used in marketing or library science, social science, and user research disciplines. They can provide us more nuanced and natural feedback than individual interviews and are easier to organize than experiments or large-scale surveys. Okay, so now there are a few steps we follow. First of all, we choose a topic of interest. So focus groups primarily are great for conducting the explanatory research where we explore why something occurs and when we have limited information available. So focus group is a good choice if we are interested in real time or responses on a given topic and discussion between the participants, or if our questions are rooted in the feelings or perceptions. And here, it's not that we just need answers as yes or no. So we more of need answers like why and how the things are happening. If we are leading a relatively small, if we are confident that a relatively small number of responses will answer our question, then focus groups are good to go. Or if we are seeking directional information that will help uncover new questions or future research ideas. Now, topics favorable to the focus groups. As a rule, we take research topics which are related to the thoughts or beliefs and feelings. They are something that work well in a focus group. If we are seeking direction or explanation or in-depth dialogue, or a focus group could be a good fit for such topics. Now let's see some example to understand it better. For example, let's take an example of a university dining hall. So if your university dining hall or a college dining hall or school dining hall is considering adding a vegan meal to its daily menu, and the university is, however, hesitant to do so because it thinks that it can lead to increased food wastage. So it needs some concrete proof that the vegan meals will be successful. Now, if we want to determine whether the student body would regularly consume vegan food, we can conduct a survey. That would be a great way to gauge the student preferences. However, we know that food is much more than just consumption and nourishment. It can have some emotional or cultural implications or other implications individually. So if we are interested in something less concrete, such as students' perceptions of vegan food or interplay between their choices at the dining hall and their feelings of homesickness or loneliness, so in such scenarios, focus group would be the best option. Now, step 2 is we have to define the research scope and hypothesis. So once we have determined that a focus group is the right choice for our topic, we can start thinking about what to expect the group discussion to lead. So setting your scope will help formulate the interviewing hypothesis and setting clear questions and recruit the right participants. For example, if you want to determine the scope of the research, we can consider following questions, taking the same example as we discussed previously. So we can ask, like, are you interested in a particular sector of the population, such as vegans or non-vegans? We can ask questions like, are you interested in including vegetarians in your analysis? We can ask questions like, will your study exclude those who don't those who eat or don't eat are or not are vegans. So are you only interested in students who have strong opinions on the subject? So these are some examples of questions we can ask. Now the step 3, determine your focus group questions. What kind of questions should be in a focus group? They should be open-ended and flexible. The questions should be such that their answers would not be just a yes or a no, but the questions should be like, they should start with a why or a how. And unambiguous, getting straight to the point while also stimulating the discussion. And also we have to keep in mind that they are unbiased and neutral. Moving forward, so here are some examples. There are a few types of questions we can use, like engagement questions, exploration questions, or the exit questions. Now, engagement questions are the questions that can make our participants feel comfortable and ease. For example, starting a question like, what's your favorite food at the dining hall, would make the participants more engaging and more comfortable or easier to talk to. Then exploration questions, like we can drill down to focus the analysis. We can ask questions like, what are the pros cons of offering a vegan option to the participants? The exit questions, we can pick up on anything that we might have missed in our discussion. We can ask the participants, is there anything you would like to mention about the vegan options in the dining hall that we haven't discussed? So these are kind of questions we can ask in a focus group discussion. Moving further is step number 4, which is where we select a moderator or a co-moderator. Now, it's essential to have more than one moderator in the room. Why? Because if you would like to take the lead asking questions, we can select a moderator, a co-moderator, who can coordinate the technology or take notes or observe the behavior of the participants. Now, step 5 is to recruit your participants. Now, depending on the research topic, there are a few sampling methods we can choose from to help recruit and select our participants. We can have voluntary response sampling, such as we can post a flyer on the campuses, or we can find participants based on the responses. We can have some convenience sampling, which means choosing those who are more readily accessible to you, such as your friends or your fellow students at your university or college, etc. Stratified sampling of a particular age, race, ethnicity, gender identity, or other characteristic of interest to you. Now, I have a question. Does anybody know what kind of bias can arise here? Anybody can tell me what kind of bias can arise here? You can write in the chat box, or I can give you an answer in a few seconds. Anybody? Okay, so here we see like a sampling or a selection bias can arise, which can occur when like some members of the population are more likely to be included than others. So that gives rise to sampling or selection bias, which we have to be taken care of. Now, coming to the number of participants, most of the focus groups usually have 6 to 10 participants. It's always good to have a little bit more than that, just in case someone doesn't show up. As a rule, we don't keep participants less than 6 or more than 12. So just between 6 to 10 or 6 to 12 is good enough to get a good, reliable result. Now, lastly, it's preferable for your participants not to know you or each other, because that can lead to bias. Moving forward. Okay. Now, step number 6 is set up your focus group. Now, a focus group is not just a group of people coming together to discuss their opinions. While the well-run focus groups have an enjoyable and relaxed atmosphere, they are backed up by rigorous methods to provide robust observations. Now, when we set up a focus group, it's very important to confirm a date and a time. So we have to be sure that we have a set time and date with our participants well in advance. Focus groups usually meet for about 45 to 90 minutes. However, they can last longer. But we just have to be aware of some of the possibilities that can, there are people have small attention spans, and it's better if you know beforehand that your group is going to go more than 90 minutes, then we can schedule a few breaks so that everybody stays attentive. Next is we have to confirm whether it will be taking place in person or online. So more like we know that an uncomfortable or an awkward location may affect the mood or level of the participation of the group members. So we, as a general rule, we make sure that there's a noise-free environment that minimizes the distractions and interruptions to the participants. Online sessions, as we know, are more convenient these days, as participants can join from home anytime, and this can also lessen the hard, like online sessions can lessen the connection between the participants, but this is, I think, a more convenient form of group discussions. Moving forward, so there's something which is important, consent and ethical considerations. So it's very important to take into account the ethical considerations and informed consent while conducting research. Informed consent means that the participants possess all the information they need to decide whether they want to participate in the research before it starts. So it could be anything about benefits, risks, funding, institutional approval, or even even we need to know whether the participants are comfortable with being audio or video recorded. Then there needs to be some preparation prior to the participation. So we can let the participants know beforehand so that they can read or study and be prepared beforehand, and be sure we need to be sure to let them know well before in advance. So it's also a good idea to call them the day before to ensure that they still will be participating. Now, step number 7 is host your focus group. So considering conducting a tech check prior to the arrival of your participants, and noting that any environmental and external factors that could affect the mood of the group that day. So we can do this by being sure that we are organized and ready before we actually start. So starting the focus group, how do we do it? We always welcome our individuals to the focus group by introducing the topic, introducing ourselves, introducing the co-moderators, and then we can go over any ground rules or suggestions for a successful discussion. It's really important for any kind of a discussion to make your participants feel at ease and comfortable, and so that they can come up with their responses. How we can achieve this is we can consider talking or making some, giving some icebreaker questions to the participants so that they can feel much relaxed and they can settle down in the space a bit. So icebreaker question, it could be related to your study topic, or it could be just any general question. It's just an exercise to get the participants talking and getting involved in the group discussion. Now, leading the discussion. Once you start asking your questions, try to keep response times equal between all the participants. As we know, we can take a note of most and least talkative members of the group, as well as the participants who particularly are strong or have dominant personalities. You can ask the less talkative members questions directly to encourage them to participate. We should also ask participants to elaborate on their answers or to give an example. Now, analyzing the data and reporting your result. So this is the last step, and after concluding the focus group, the moderator and the co-moderator should debrief, record the initial impressions of the discussion, as well as any highlights, issues, or immediate conclusions that they have drawn. The next step is to transcribe and clean your data. Transcribe the recordings and conduct the content analysis to look for categories of responses, which then form the basis for the reporting of the results. Advantages and disadvantages of focus groups. Now, just like any other research methods, there could be the pros cons of this focus group too. So what are some of the advantages? They are fairly straightforward to organize and easy to have strong face validity. So what is face validity? So face validity is something whether a test appears to measure what it's supposed to measure. And in terms of research, face validity is how the researchers review the work of other researchers. So that is about face validity. And the other advantages of focus groups are that they are usually inexpensive. And they are less time consuming than a survey or experiment. And you also get an immediate result. Focus group results are often more comprehensible and intuitive than raw data. Going to the disadvantages, it can be sometimes difficult to assemble truly representative sample. So focus groups are generally not considered externally valid due to their small sample size. External validity is the validity of applying the conclusions of a scientific study outside the context of that study. So that's what is external validity. Now, other disadvantages could be like due to the small sample size, sometimes we cannot ensure the anonymity of the respondents, which may influence their desire to speak freely. Others are like it can be sometimes challenging to get the honest opinions on controversial topics. There's a lot of room for the error in the data analysis and high potential for observer dependency in drawing the conclusion. I hope it was a little useful to you guys. So that's all from my side. Thank you all for your patient listening. Thank you so much and have a great weekend.
Thank you so much, Saima. Saima, and this is great, excellent presentation. I just shared with you guys a link to a paper that my team and I published 3 years ago. So using the same method of the topic. And what we did is we have older adults in our area, in Lansing and the neighborhood. Some of them were from MSU, some in the surroundings, and some from other assisted living. So if you have time, you can look at that and you can have a better idea about what we just talked about, the method. But thank you so much. Any questions?
Thank you so much, Dr. Nadir, for that insight. And thank you, everyone. Thank you, Dr. Saima, for a good presentation. Next one, if everyone's okay, we can move on for project updates. If anyone has any updates on the project. Go ahead, Mafaz, please.
I just had one question for Nadir regarding the pediatric vaccine app. When
we are not able to.
The app, yes.
Sorry, can you raise your voice because we're
I'm so sorry.
Not able to hear properly.
Is it clear now?
Yes.
Yes, okay. So regarding I had one question about the pediatric vaccine app. When we published it, now it's saying that we reached the maximum amount of users, which is only 10 users. So I'm not sure what's the issue exactly. We had the informations going to the users tab, which is for the Glide app. I thought maybe it's that's the problem. So I made a different Excel sheet for the users. but this did not go away. So I would like to know how can I fix it?
So it's still in Glide app?
Yes, it's still in Glide app. We still did not do the coder yet.
So you are talking about how many users they can log in the app?
Yes, the amount of users, it says that we reached the maximum amount of users, but it's only 10 users right now.
Yeah, sometimes they change their plans, like the free version. So if you don't mind, we can discuss after the meeting.
Yes.
And go over and see how we can fix it.
Yes, thank you.
You're welcome. Anyone else?
Dr. Nadir, there is a question in the chat box earlier from, I think, Dr. Mesam about asking about the people who have published systematic review before. Have anyone registered for the review protocol in Cochrane or Prospero or other areas before starting the actual work before, or is it not mandatory? Do you have any ideas or comment on this, Dr. Nadir?
I'm not sure if in the group anyone from the any fellow who published systematic review, any answer? Go ahead.
Hey everyone. So if the question is not clear, we're starting to work on a new systematic review, and I just wanted to know if it's mandatory to register our review protocol in places like Cochrane or Prospero or these other avenues, or is it not a mandatory step and we can directly proceed with our systematic review?
I believe, if you ask me, I believe if it is, I think it is necessary because it is part of the guidelines. If you go into the Prisma checklist also, which I added the link in the chat box, it does, I think, ask for registering it. So I'm not quite sure if any fellows submitted recently. Most of the fellows, I believe, had done a literature review. So
hello.
Yes.
So regarding the question, the protocol, I think it's important to avoid for the duplication because like currently there might be other researchers working on the same topic and they might get their work published already before you do. So if you got the protocol registered, you do actually preserve your spot. At the same time, most of the journals with the good impact factors, like the first thing they ask about is your registration number. So if you do that, you do widen your, your scope of you getting your manuscript published in the future. So I think it's better to work on the protocol. However, you can work at the same time while you already start on the process of conducting your systematic review. It's not like you have to divide the task. And actually, me and my team, we're working on a systematic review. It's a neurology based. So we're doing the same. We have already started to work on the protocol at the same time on the project itself. So I think it's better to start to work on the protocol. And I already have the Cochrane guideline for writing the protocol. I might share it with you guys. Thank you.
Thank you so much. Any other questions?
Hello, everyone. My name is Dr. Ayman. I'm speaking on behalf of the Purple team, led by Dr. Salma Ali. I would like to update you regarding the team works. Currently, we're working on 3 topics now. We started on one systematic review. We discussed the research protocols, and we determined the research question for the systematic review, and we started reviewing the articles. The second one, we also a systematic review on post-COVID mood changes among geriatric population. Also, we determined the protocol. We start soon to reviewing article. The third one is the cross-sectional study, almost done. Just need reviewing regarding knowledge CAP study on knowledge among diabetic patients of diabetic complication and food self-care practice among those patients. Thank you.
Thank you so much for the update, Dr. Ayman. Anyone else? Can I just share with you while if you have comment or questions? Here's an old document where we try to keep the projects, current projects. So I'm going to share that also with you in the chat. If you want to update whatever we are working on, that would be great. So basically, we have some app development like blood pressure, dental app, epilepsy, oncology, and a couple of new ideas we are working on here. So you can click on any of the link and add yourself if you are interested. Usually we ask for the papers or the abstract to be 10 people or less, but for the applications development, any numbers, there is no limitation. And you can look at the previous projects, and one idea is to convert some of these. Most of them are abstracts, and if you are interested in one topic, you can create a new project to convert the abstract into a manuscript. So I'm going to share this document with you guys on the chat, and hopefully it will help some of you. Go ahead, Dr. Faida.
Hello. Can you hear me?
Yes.
Okay. So me and my team were already working on the neurocognitive implications of COVID-19 on adult patients. We have already started the project. We started on the protocol, and we're already done with like half the way of the methodology and the background. So by June 10, most likely we're going to be done with the data collection. And inshallah, hopefully after that, like we can go on to write our manuscript. But this is the update still now.
Excellent. Thank you so much for sharing.
Thank you, Doctor.
Any other ideas or suggestions? If none, we can go to the next topic. So for this topic, I'm gonna just share with you, it's about the SPSS. So to make life easier, some of you might know how to use SPSS, some might not know or have no idea about the statistics. I'm gonna use Excel to start with. So we can go to Sheets, New, and hit Enter. So the idea here is to have data collected, let's say, from subjects. So to do that, you need the subjects. So subjects, you can put the subject, let's say subject number 1 here, subject number 2, and so forth. So 2, 3, 4, and so forth. This is one way of doing collection about certain, let's say, we were talking about systematic review. Instead of subject, it's going to be study. So this is going to be study number 1, study number 2, and so forth. So you have the study, you have a number for the study, or you can identify that specific study with an ID. So this ID will be specific for the study, or in case of subject, for the subject, so that you can collect the specific information about that subject or study. And this will help us in the database later on. As you can see here, the first column is text only. It's subject. It could be the name of the patient, whatever. It's only letters. Could be combination of letters. The second column is numbers only, and then the third column, the ID could be a combination of this and. So it's going to be combination of the name or the text and the number. So there are different ways of adding your information in the sheet. So you can save this in this way, or you can save it in a different way, where you can, instead of vertical, you can do it horizontal. So the subject will be first row, and the number of each subject will be the second row, and the ID will be the third row. So this is not the preferred way of collecting your data and saving it. So we are not going to do that. So in SPSS, we're going to collect the information. We're going to save them in similar format like this. So each row will have a subject and then the detail of that subject, or a study or any item, and then the details of the item. I'm gonna, okay. Now I'm gonna ask you a question to make this interactive. Just so in the polls, the poll section, if you want to let me know which your gender. Are you female, male? Can you do that for me? So we have 90 participants right now. So I can stop here for now. So it's 30 versus 9, okay? If I go back to my sheet, just for the discussion purpose, and the gender, each one of you will have 1 or 2, indicating 1 is male, 2 is female, for instance. Okay. So this is how I can collect for each individual. And the total will be like, I can total all them. In your case, it was 9, or let's say 9 males and female. So in this example I just showed you, the Zoom has collection of all the fellows, and when you enter your information, it will be in one line, and then for me it collected the male, calculated how many, and then females how many, and gave me the end result. Out of the total number is 39, for example. So all this was done by Zoom, and there are different application or tools or software that can do the same. But for the purpose of this, how to use SPSS, the first task is to collect the information. And to collect the information, you need a spreadsheet like this. You need the variables like the number, ID, gender. The first line here, we call it variable. And then you need the subjects or the lines or the rows where you will put your subject or study or any item that you want to collect the information about. So this is a basic way of doing that. The second way, when I ask you, I put M for male and F for female. So to display the question for the user to click on something, you can either display it as the whole word male or the female, or you can shorten it into M or F, or you can use 1 or 2 as a code for saving your information or in the database. So when using numbers, it makes sense when you are calculating later on. If you are using text, some people might misspell if they want to say, I'm a male. If you let them type, it will have some spelling mistake and so forth. If you give them the option of clicking, it's better as far as the data. And then the shorter version is better to communicate and collect all the information faster. So I'm going to stop here. Any questions so far? If no, we will go to the next step where I'm going to share with you again. So the next step is after you're collecting all this information, you will have different sheets, like sheet number 1. When you eat, you can get a sheet number 2 or a sheet number 3. In SPSS, we call them windows. So the first window will have this information like the variable. In the second window, we can save this. So we can save this as the use of numbers for your data collection, what it means, and what's the shortened version of that. And in the third window, we will discuss about how you manipulate, how you give instructions to collect, let's say, how many males in this sample, how many females. So it will calculate, add all the males, and then do the math for you. To do that, I'm going to share with you, there are a couple of videos here. So I'm going to stop sharing and share again. So if you go to Google, you want to learn about SPSS, you will use SPSS tutorial, use YouTube, and you will find a lot of short version, like 15 minutes or less, beginner kind of guideline. This course is about 2 hours. You can spend time on that, but there are other options. For example, this option here, it has a free course. It's an open learning module. So you go there, you log in, and you can enter the course. It's free, and it's small pieces. You can download the steps or what you're going to learn about that in PDF format or Word format. So this is another way of doing it, like getting started with SPSS. So it's free, either using the tutorial from YouTube, and we have a couple of other YouTube samples. For example, this one, done by Research by Design. They have 8 videos, short videos, and you can follow the videos. You don't have to download the SPSS itself, because I think there's an online version, but they will tell you what the first step. This one is about how to build the variables, and then there are part 2, part 3, and you can play all these videos together. So it's kind of a neat way to learn more about SPSS. It may sound like difficult, but it's not, at least the first couple of slides for the beginners. When we talk about the analysis, we can also talk piece by piece and demonstrate that in a short version, so that you can understand. Let's say we want to compare group A with group B. In this example we just took from you, 30 females against 9 males. So if I ask, what's your favorite food? So the female will write certain things or select certain things. Male might be different. So I want to analyze what's the difference between the 2 groups. Does it matter, or is it significant, being a male to choose certain food or female to choose a different one? So you can use, for example, t-test. So we will go over how to apply t-test between 2 groups, something like that. But the first thing is how you keep the data in one place and clean and make it ready for the analysis. So we have 3 windows. The first window is the variable or the data structured as column and rows. The second one is the design of this data, like what it's in each field or variable, what you want to save, how you want to save it, and how to make it user-friendly so that they don't put information that's wrong or not useful for you for the analysis. So I just want to share with you that. Hopefully you can either go through the YouTube videos that I shared with you or the free course. I think it's 8 classes or something. And you can advance as you think you obtaining more knowledge and skills. The reason I'm saying that, because SPSS is one tool. There are different ones. There is R tool. There is STAT, I think, another different tool to analyze things. You can use Google Sheet or Excel for simple statistical analysis methods. But for complicated one, you need to learn more about that. When you learn these basics, you can advance and you can put that in your resume when you apply to other, like if you are applying for residency, when they look at you and see you already know SPSS, that's a significant impact, that you know some basics of the research work if you want to do some research work. So it's going to be helpful for you guys. Thank you so much. Any questions or comments? Haifa, go ahead.
Assalamualaikum. I just, like this is my first time and I feel I am in the middle of nowhere. So is there any advice for me? Because I don't have even previous experience in, like doing research. I checked the email that you have sent it to me regarding how to use the Excel sheets and all this. But I mean, like from where to start? For example,
so if you got the steps, I want you to start. Like if you have Google account, if you don't, create one. If you have one, go to the next step, create a sheet like the way I just did, and Google Sheet. And if you know Excel or if you know Google Sheet how to do this, that's fine. If you don't, you can look up some of the tutorial in the app itself. we have some tutorial about how to use the basics of Excel sheet or Google Sheet, how to start, and also how to advance. So some of the analysis we just talked about, it can be done in Google Sheet or Excel as well. So this first step for you, if you have time to look at some of the videos and apply some of the concepts if you have Excel or online Google Sheet. And then you can collect more skills or information as we go along. Thanks.
Okay, thank you.
You're welcome. Your team will help you as well. Go ahead, Saba. Saba.
Thank you very much, Doctor. Before I ask anything, I just want to thank you and for putting together a very such an educational presentation for today. And I'd like to thank the rest of the fellows for putting an effort into such good presentations. So thank you, everybody. So I'm still new to the team. I just joined a few weeks back, and I'm still trying to understand how everything works. I went through the Google spreadsheet that you shared with that has updated information of all the projects. So I wanted to ask if I would want to update any of the projects because I didn't know. I've been working with the blood pressure app team, and I did not notice my name there. So I just want to know whom should I reach out to in order to update that. And secondly, I wanted to ask, are there teams assigned, or do we have to, am I supposed to reach out to different team leads and ask them about any incoming projects they have or anything I could be a part of?
Thank you so much for your comment, and thanks for the question. So the fellowship itself, we try to organize it into teams. So each team will have a leader, and then this leader can be changed every, let's say, a couple of weeks or 1 month, something like that. And the leader can organize, let's say, same what Mihir did today. For example, when we want to plan for next week, the next team will have the leader assigned or ask the fellows in that team to see who's available to present. And sometimes they can present 2 or 1 or more, one topic of the topics that we will be discussing and presenting next week. So your team will just help with that. Another idea of the team is to know who will be available, who will not be available, so that some of you might be preparing for step 3 or other involvement in life and may not be available. So when you tell your team leader that, hey, I'm not available during these weeks or months or whatever, then at least we will have an idea about who will be active so that we can ask them to participate or do some of the tasks that we want to do. So the team leader is the one go to. If you have questions, they can answer. Most of them, they will be seniors, so they spent some time in the past knowing how we run this program. So if it's simple question, they can answer, and they can lead you or direct you to the right way. The other part of the organization of this fellowship is we need to work on projects. So let's say we have one come with idea today. So this fellow can be the leader for that project. And he or she can open the floor for, hey, I have this idea, I'm gonna start this project. I need some people to work with me. So if it's an idea for abstract, we want to limit the number to 10, because when we finish this project, when we submit it to the conference, they need us to be a limited number of authors when we apply through their website. We cannot be 20 because they have a limit number of authors. So we found out in the past that 10 is kind of a good number, average number for an abstract. If your idea is to write a manuscript, the number might not be as limited, depending on what journal you want to submit to. I have seen articles that published with 20 or 30 authors, or maybe more, like guidelines articles. So there's no, it's flexible, the number. On the other hand, we have some app development projects. So each app development project will have a leader for that project. And the number there is also not limited, because you can just participate as you can. And it's going to be published in the app itself. Your name will be listed there. But we want you to participate. You take a task of that app development, and you can work either on data collection or developing the app or testing the app, or and then presenting this app in other, let's say we want to publish app in conference or in a meeting. So some of you might be able to do that. So this is just a part of organization about how this fellowship works. Then we come to the educational part. This meeting, we try to divide it into 4, 5, 6 sections. Each section will have a component. So the first component is the knowledge. So this fellowship primarily based on geriatric, but it can be other topics, but we want to focus mainly on geriatric as far as the knowledge, because we need geriatrician, or at least we need healthcare provider who will work with geriatric population. As we know, the number of older adults in the US is increasing. Number 2, if you are in the medical field, you want to go to apply for residency. For example, if you want to be a unique among the other applicant, if you tell the program director or interviewer during the session that you are interested in geriatric, you might have a better chance of accepting you into the program, as most of the family medicine or internal medicine works and wants you to work with patients who are older because they see them a lot. We have, however, some of the fellows have different interests. Some of them might be interested in radiology, pediatric, psych, or pathology. So this knowledge will help them, even if it's just working with their family members, like older adult in the family, or in like parents, grandparents. So hopefully this will help on a personal level at that aspect. The second component is the skill, as we just mentioned about the tools that can be learned, and you can mention it in your CV. The third component is like improvement in your project or skills in research, the same way we talked about the methods. So how to develop systematic review, how to carry that on, or how to do the focus group. Sometimes we talk about other personal skills like organizational skills, confidence level, and so on. And then other skills like language. So there is one fellow who speaks the Spanish language, and she is training some of the fellows to learn medical Spanish language. So these are some of the things that we work together on in a nutshell. So if you have questions, if you are new, I'm going to assign you to a team, and in that team you will find a leader who will contact you, and then develop a WhatsApp group. I'm in the process of dividing the white team into different small teams because the number increased. So you will hear from me soon. We'll assign some new teams and new team leader for these 2 teams. So just we'll update you as we go along.
Thank you very much, Doctor. I look forward to it. Thank you.
No problem. Thank you.
Dr. Nadir, I have something to add actually. So the new fellows, I want to let them know that we have some WhatsApp groups. If they are not into the WhatsApp groups, they may want to be in. We regularly post specifically about the different teams we have. All Most of the teams have their own WhatsApp group. So when the time comes, when there is a presentation coming closer or sooner, team leader or they usually post on the group, and to see who's interested to do. That's kind of a good way of communication there. So I think, and that is all helpful, and so far in my experience, all the fellows are very helpful and assist with doing the presentation and other things. So, and that being said, I appreciate fellows today coming up, on short notice. We just like 2 or 3 days ago, we came to know that we need to, do this presentation today, and everybody just came forward to do it. So I really appreciate everyone's effort here, and thank you so much for giving us opportunity.
Thank you so much, Mihir. So excellent. You raised a very important point that this program, it depends on each one of you, and we are here just to organize stuff. So whatever method you think it's working, as Mihir mentioned, the WhatsApp is very useful tool, so you can use that. And sometimes we have short time to organize things. But thank you so much. I'd like to thank you, Mihir, again for organizing this meeting and moderating it. And also I'd like to thank all the speakers and all the attendee for attending this Zoom meeting. Thank you once again, everyone, and I wish you all the best. If you have any questions, let me know. You can send me an email or text me, call me. I'll be happy to assist, and we'll see you next week.
Thank you, Dr. Nadir. Thank you so much. Thank you, everyone.
Assalamu alaikum.
Thank you, Dr. Nadir. Thank you.
Thank you so much.
Thank you, Dr. Nadir.
Thank you, Dr. Nadir.
Thank you.
Thank you, Dr. Nadir.
Thank you, Dr. Nadir.
Thank you. Mafaz, are you still there?
Dr. Nadir, I'm here.
Yeah, so we can go over let me answer this, and then we can go over the question about the app.
Yes.
Ya Allah.
All right, go ahead, Mafaz, sorry.
So a couple, I think 2 weeks ago or 1 week ago, someone tried to log into the app and they had a message that said that the app reached the maximum amount of users. And when we check out the number of users, it says that's only 10 users. So in the beginning, we had it that the information would be added to the Glide app itself user section of the spreadsheet. So this is the logins from the Glide app. So I thought that was the issue. So I made another spreadsheet for the users, and it actually worked. But then the same people that were trying to log in, they said that they didn't have access. So I'm not sure what was the issue exactly.
So there are a couple of things. The user tab that you are using now supposed to be linked to the app when you go to the app tab. Supposed to
In
be
the app itself?
in the app itself, yeah.
I think I changed it. I changed it in the settings. I changed it from the users tab in the Glide app. I changed it to the one in the spreadsheet.
So you already changed it, and
yes, I changed it.
The other question is each one of the fellow or the user, they use the same email in that list? So in the Excel sheet now you have 2 emails.
Yes.
Any of these 2 emails, the user tried to log in and they have problems? Or
Yes. So I remember because I was speaking to the person that was trying to log in. So when she tried to log in, it appeared to me that the email is actually logged in, but she wasn't given access to the app.
Okay.
And then I saw this, I didn't understand what's the agreed part.
No, that's insignificant. That's beside. Why don't you delete from row 3 all the way down? Delete all this.
From here?
Yeah.
Okay.
Yeah.
Okay.
Yeah. So can you go to the app sheet again? Or okay.
To the app itself or the
app itself, and
yes.
Go to the corner on the top left, not the app, but the window. There are dots on the top left beside the app title.
Data?
The icon beside it on the left side there. Yeah, hit this.
This?
Yeah. It will take you to all. Yeah, hit it. So on the left, there is project, members, and usage. Click on the usage. So maybe the editors here, they're supposed to be 2 editors on the right side.
Yes.
So there are 4 editors.
Okay.
So maybe that's a problem. They have some limitations.
The editors are the members?
I'm not sure where is the editors. Go to the project again, go up to the project. So you have other apps, right? Copy. These 2.
Yes, the adult app.
Can you move them to click on the dots on the top right corner? Yeah. And create, where is, no. Okay, go to the left, all the way to the left, and at the bottom, no, all the way to the menu and create team, new team, and maybe all, what's adults, yeah. 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 Yeah.
Not using it for work.
Yeah. And continue. So now go to the, okay.
I'll skip.
Yeah. Now you can go back to the, not the vaccine app, but the group before, on top of it. Yeah. And then you can move these to transfer to the vaccine. Yeah.
Okay.
Transfer. And do the same. This might be sometimes they have certain things that so if they try it again, hopefully go to the usage again, go on the left usage. In this app, do you have more than one editor?
It just says the public users are 10 out of 10. So I think that's
the problem.
The issue.
Okay.
Yeah.
Okay. Why don't you use it as without login? Go to the app again.
Okay.
Click on it and then on the security. Privacy.
Yes.
So you have it. Yeah, not required. And click it.
I can't unclick.
Go up. So private, public, signing.
I can make it private. But option sign in.
Mm-hmm.
For only users you choose can sign in.
I'm not quite sure. Otherwise, for you, is it working?
Yeah, for me it works. I think the ones that signed in before the issue, it worked, but the ones that's going to sign in, they can't sign in.
Mm-hmm. Okay, just a second. So what I think, go to layout in the middle, layout on top, beside setting, to the app itself, go up, yeah, layout. So go on the, yeah, go with the mouse up, yeah, here, the user, yeah, go up, no.
Here.
To the left, and a little, go left, and then up here, up, no, not all the way. Go right, go up, no, in between the two. So yeah, go one more, no, left.
To the left, yes.
And then up.
Yeah.
Here. Yeah, it's supposed to give you the users. So we have 3 users. So any of these users available to test the app, you can click on one of them, it will test the app, how it looks for them. So if you click the one below, it's supposed to give their info. Click here, yeah.
The users.
Not the users, but outside here, yeah. This is how they will look at it. So they need to. So here the file is, yeah. So I think
if we can change it back to the Glide app users, and then maybe, yes.
Right. Instead of this, the users in the Glide app.
Yeah.
And then
because we deleted, maybe it will add up more people.
Do me a favor, go to data app. One more up. Yeah. And then see the users. These are the 10 users.
Yes.
Maybe there are more than 10.
More than 10.
Yeah. If you can delete some of them and ask the rest to.
For some reason, I was never able to delete anything from the sheet that's in Glide.
No, click hover on the left, yeah, here, and then click it, and then hit on the keyboard, delete.
Okay, that's nice, thank you.
Yeah. So let's try that and see if it's not.
I'll delete all of them, and then, yes.
Yeah. Let me know when they try it again if you have problems, okay?
Yes, thank you, Dr. Nader, very much.
Thank you. Assalamu alaikum.
Hi, Dr. Nader.
Hello. Hi, Amal. How are you?
I'm doing great. How are you?
Excellent. Excellent. Thank you.
So I just searched the Glide community. They say that they limited the number of private users to 3 and public users to 10. So I think this is a new plan.
Oh, yeah. They want people to pay. Yeah.
Yeah.
They said it's free, but now they are limiting.
Yeah. So I have update. Sorry for that. I have updates regarding.
I want to just double with my fast. If we can use it with couple of within the 10, and if it's working, then we can transfer that to what's called the other no code. Yeah, Clodar. So you can try that. But this just for the concept and how things will lay out and so forth.
Yes, thank you, Dr. Nader. I was also like in close time we'll transfer it to Codular. So for this issue, like I'm actually we're considering it to transfer it. It will be better for us.
Yeah.
Because of the limit. Yeah.
Sure. Yeah.
Thank you.
You're welcome.
Have a good day.
Have a good day. Assalamu alaikum. Go ahead, Aman. Sorry to interrupt.
No problem. So we were very excited to present our Arabic version of Ayan Argar by this meeting, but the video maker said that she needs an additional week to be able to complete all videos. So we're hoping to be done and present our work by next meeting, inshallah.
Sounds great. Thank you so much for updating.
Thank you, Dr. Nader. And we added more features to both the Arabic and English version. Like we added, patients can customize their dosage. Yeah, and we're working on it to make it better.
Excellent. Yeah, that's the way. So excellent. I think you are doing great, you and your team. So keep doing that, and hopefully we'll have a very good product. Yeah.
Yeah, inshallah. Thank you so much.
Thank you. Enjoy while you can. Assalamu alaikum.
Wa alaikum salam.
So everyone, salam.